Oh, okay. Okay. Hello? Hello, can somebody confirm that you can all hear me? Hello, am I audible?
I can hear you.
Okay.
Yeah, you're audible, but you can a bit louder.
Okay. Yeah, is it better now?
Yeah, I think it's better.
Okay, so
better.
Good evening all.
Good evening, sir.
Good evening, sir.
Yeah, you are all welcome to the Nma Taraba 2026 AGM activities starting this evening with the CME programs. As you can see from the shared layer, have a lot of packages for you. So pay attention and get enriched from the topics that have been selected by experts in the areas so that you can actually benefit from the outcome of the presentation. Before we call on our first speaker, may I invite the chairman of Nma Taraba, in the person of Dr. Adokara, to give us a goodwill message and welcome us all so that we can set the ball rolling for the presenter to start immediately. The Nma chairman, sir.
All right. Thank you very much. The chairman, CME committee, Dr. Tsiterimam, and his team, my distinguished colleagues, our respected resource persons, invited guests, ladies and gentlemen. I sincerely welcome you today to this meeting of our education and on behalf of the SOC and the CME committee. I sincerely want to welcome you all and sincerely appreciate you for being part of this important meeting despite our schedules. We all know that medicine now is constantly evolving, evolution, and continuous regulation therefore become so necessary for all of us so that we can keep abreast of current practices. So I wish to express my sincere appreciation to all of you, especially the facilitators, for accepting to share their expertise with us today, and then looking forward and engaging in productive and enlightening presentation. Without taking much more time, once again, I welcome you all this evening. I'm sure you are going to listen and gain much from this presentation. Thank you once more, CME Chairman, CME Committee, and the team for your wonderful job. So thank you.
Thank you, Mr. Chairman, sir. And once again, thank you everyone for joining in this first day of our CME session. So I think we just start straight ahead so that we don't waste time. May I invite our first presenter in the person of Dr. Sambo Tsiterimam. He is going to take us through the management of urologic complications following gynecological or obstetric surgeries in our practice. I believe it's going to be very helpful, particularly for our colleagues, probably in other health facilities. Dr. Tsiterimam Sambo is a consultant obstetrician and gynecologist working with the Obstetric and Gynecology Department of Federal Medical Center, Jalingo. Dr. Sambo, the floor is open for you. Thank you.
Thank you, Mr. Chairman and the Chairman CME Committee and the team. As introduced, I'm Dr. Sambo, Department of Obstetric and Gynecology, Federal Medical Center, Jalingo. I'll be taking the first CME, managing urological injuries in obstetrics and gynecological surgeries. I'll go right into the presentation. All right, so these are my outline. So by way of introduction, urological injuries are rare but significant complication of obstetrics and gynecological procedures. They are associated with morbidity, prolonged hospital stay, and in some cases, medico-legal implications. The shared embryological origin and the anatomical proximity of the urogenital system with the reproductive system contribute to the relatively high incidence of iatrogenic urinary tract injuries during obstetric and gynecologic surgeries. So by way of epidemiology, the incidence rate of urological injuries in pelvic and abdominal surgeries is fixed at 0.5 to 1.5%, and bladder is commonly involved. About 75% of urethral injury results from gynecological operations, and 75% of them occur following abdominal gynecological procedures. Hysterectomy, one of the commonly performed gynecological procedures, is responsible for 38% of all the urologic urethral injuries. So these injuries can be broadly categorized into acute, subacute, and chronic. Acute when it is less than 6 weeks from injury to presentation. Then from 6 to 12 weeks is subacute, and then chronic type is occur or present more than 12 weeks from the onset of the injury. There could also be bladder injury or urethral injury. We'll go straight to urethral injuries, being the most complicated and the most difficult to manage. We will later look into the bladder injury. So urethral injuries are defined as any recognized or unrecognized trauma to the urethra that prevents it from functioning properly or effectively. The incidence is about 0.03% to 2% in experienced surgeons and up to 15% in an inexperienced surgeons. So this is very important in this webinar, considering the wide range of individuals carrying out gynecological surgery in our environment. So the injury to the ureters is one of the most serious complications of pelvic and abdominal surgeries. It is a constant threat described as a sword of Damocles hanging over every major surgery in the pelvis. This sword of Damocles is a tale, a moral tale that was told of a king named Dionysius of Sicily, who had a servant, Damocles, who always praised him of being the happiest and the wealthiest king. And then this king also was not so impressed. He decided to vacate his throne for a day for this Damocles to sit on that throne to experience what it feels like being a ruler. So when this Damocles was on that throne, and then the servants were praising him, were giving him all this entertainment, he looked up, and then above him was a very sharp sword that was just hanging by a thread of horsehair. Damakol immediately became dissatisfied and afraid of the throne, and he pled to leave the throne. So the moral is that all the rulers have imminent danger ahead of them. So that describes exactly how gynecological surgeries are a threat to having to injure the urethra. So relevant anatomy is very important in this presentation. The urethra, as we all know, is an expansile tubular structure that measures about 25 to 30 centimeter long and 5 millimeter in width, and then it extends from the renal pelvis down into the kidney. It extends from the constriction at the junction of the pelvis to the kidneys. The abdominal is divided to abdominal and the pelvic ureter of approximately equal length. So this is brief picture of the anatomy of the ureter as it finds its way lying medial to the psoas major muscle, overlying and enters the pelvis at the bifurcation of the common iliac artery, and then overlying the iliac vessels, and then it also enters, goes lying by the pelvic side wall, and it enters the pelvis at the bifurcation of the common iliac artery in front of the sacroiliac joint. The pelvic ureter runs on the lateral wall of the pelvis in front of the internal iliac artery and just in front of the ischial spine. It turns forward and medially to enter the urinary bladder about 1.5 centimeter above the trigone. So in the female, the ureter passes above the lateral fornix of the vagina, 2.5 centimeter lateral to the supravaginal portion of the cervix, and lies below the broad ligament of the uterine vessels. That's where it goes below the uterine vessels, popularly known as water under the bridge. Then the intravesical ureter passes obliquely through the wall of the bladder for 2 centimeter, and then it now opens into the ureteric office of the bladder. So it has multiple blood supplies that gives it its own healing capacity from the abdominal portion. It drives blood supply from the renal artery, the ovarian artery, the aortic branches, and then in the pelvis, it also drives its blood supply from the uterine, vaginal, and middle hemorrhoidal vesical vessels. It is recognized intraoperatively as a pale glistening structure, tubular structure, and then it has longitudinal vessels running on the surface, and then it also has peristalsis when it is touched. So the commonest sites of ureteric injury includes the level of the infundibulopelvic ligament, where the ureter runs parallel to the ovarian vessels and then forms posterior boundary of the ovarian fossa. Deep in the pelvis, it also lies below the level of the ischial spine, where the ureter lies lateral to the peritoneum of the uterosacral ligament. Then at the level of the internal cervical os, 1.5 centimeter lateral to the cervix, where the uterine artery crosses the ureter from above, and then over the anterior vaginal fornix, where the ureter it lies within the ureteric tunnel of the cardinal ligament, known as tunnel of Wathen. And then it also has the intravesical part, which is also commonly injured. This is the cause of the ureter. So ureteric injuries can be classified into proximal, middle, and distal third. The proximal part is when from the ureteropelvic junction to the sacroiliac joint, and then the middle portion overlies the iliac vessels, and then the distal portion lies from the iliac vessel to the bladder. So our American Association for the Surgery of Trauma classify ureteric injuries into grade 1 to 5, with the grade 1 being the mildest of the injury, hematoma, contusion, or hematoma without vascularization, with the most severe form in being the laceration, which there could be avulsion with greater than 2 centimeters of devascularization. There are so many mechanisms of injury to the ureter encountered in gynecological surgeries. It ranges from simple kinking of the ureter to angulation to crushing, crushing ligation, incorporation to ligation. The ureter could be contused. There could be transection, which could be partial or complete. There could be avulsion. And then there could be injury due to staples in laparoscopic surgeries. And then there could be ischemic injury when the ureteric sheath is damaged. That's compromising the blood supplies. Then there could be segmental resection of the ureter. There could be crushing injury from misapplication of clamps. And then there could be thermal injury when diatemy is used. The risk factors for ureteric injury encountered in gynecological surgeries, gynecological obstetric surgeries include factors, anatomic factors. These include the association, close association or attachment of the ureter to the peritoneum predisposes it to surgery, to injury. Then the ureter is also closely related to the female genital tract. So any procedure on the female genital tract can predispose to ureteric injury. Then the ureter runs a variable course. We said earlier that the length is about 25 to 30 centimeters, right from the pelvic calystial, pelvic ureteric junction down to the urinary bladder. So along this course, any procedure along this course can endanger the ureter. And then the ureter is also not easily seen. It is a retroperitoneal structure. However, it is closely associated with the peritoneum. So it is not seen, but very close. So any mistake can endanger the ureter. Then there are pathological factors based on the pathology that is being treated. Congenital anomalies of the ureter, like duplex ureter. This makes the ureter, the normal ureter, the two ureters, one may take an abnormal course, and because of this pathology, it can endanger the ureter in surgery. We also have ureteric displacement from enlarged uterine size, prolapse, tumor, or cervical and broad ligament swelling. This alter the course of the ureter and endangers it. Then, when there are adhesions, probably from previous surgeries, endometriosis, or pelvic inflammatory disease, this is often alter the course of the ureter and predisposes to injury. Then there could also be distorted pelvic anatomy. Then technical factors, when there is intraoperative hemorrhage, and when attempt is being made to secure hemostasis, ureter can be in danger in such situation. Then when there is coexisting bladder and ureteric injury, bladder injury is more obvious and will make the surgeon to miss the ureteric injuries. There are gynecological procedures that are commonly associated with this ureteric injury, which include the following: hysterectomy, simple extrafacial hysterectomy, which is one of the most commonly performed gynecological surgery, has the risk of ureteric injury of 0.04 to 3%. But the one with highest risk is Wharton hysterectomy, which is radical hysterectomy. Because of the extensive dissection that takes place, it endangers the ureter in a lot, and the risk is up to 30%. Then we have oophorectomy. This simple oophorectomy may not endanger the ureter, but if there is adhesions, there is inflammation, there's enlargement, can endanger the ureter. Then we have bowel suspension for genuine stress urinary incontinence. And then for vaginal procedures, hysterectomy, vaginal hysterectomy, though very rarely the ureter is injured, but it's a possibility. Then we have other procedures as we can see. Then laparoscopic surgeries. In laparoscopic surgeries, ureter can also be injured in different surgeries, like when arteriolysis is being done, or when ureterosacral ligament is being transected, or during compost suspension or sterilization procedures can endanger the ureter in this situation. So most common site of ureteric injury, though opinions vary, but majority believe that at the pelvic brim near the infundibulopelvic ligament, ureter is commonly injured at this site. The most common procedure is simple abdominal hysterectomy. And the most common type of injury is obstruction when it is incorporated into the ligature. And the most common activity leading to the injury is when attempt is made to secure hemostasis, especially during the clamping of the uterine artery and there is bleeding. You remember the uterine artery is above the ureter. Ureter goes under the uterine artery. So during that attempt, ureter can be injured. And the most common time is, there's no most common time, about 50% of cases is discovered intraoperatively and 50% of the cases is post-operatively. What of obstetric procedure? It's not common, ureter is not commonly encountered in obstetric procedures. However, in emergency cesarean section, about 0.02%, 27% of cases, ureter can be injured, especially when there is hemorrhage and attempt is being made to secure hemostasis. That is the point at which ureter is commonly injured. Or when there is cesarean hysterectomy, and then when there's repair of cervical laceration, especially those that are around the lateral fornix. Ureter can easily be caught up in the ligature. So management involves good history, physical examination, investigation, treatment, and prevention. So in the history of when such patients present depends on the mode of presentation. Some can present early, some can present late. So the mode of presentation varies. However, histories of the surgery in which the patient had, the history of the condition necessitating the surgery, we can have an idea of the risks of ureteric injury in such procedure. Then signs and symptoms are usually subtle and they can be overlooked except if the damage is extensive. The patient can present with anuria, especially within 24 hours of the surgery. The patient, if the injury is bilateral, the patient will not be making urine, or there may be hematuria, but this is often not a reliable sign for ureteric injury. Then patient can have features of peritonitis. This can present within 7 days of the injury. When there is urinary ascites, chemical peritonitis can set in. There may be ileus, and then the patient can present with loin or flank pain when there is ureter is obstructed through ligature, and the patient can also present with fever, dribbling of urine from the vagina, or oliguria that will suggest ureteric injury. And investigations are very important to make the diagnosis and to offer prompt treatments. As simple as 3 swab tests can differentiate from ureteric injury from vesico-vaginal injury, fistula, or mere urinary incontinence. Here, the examiner puts 3 sterile swab into one. The first swab will be put at the high vagina, the second one at the mid vagina, and the last one the lower aspect of the vagina. Then the bladder is catheterized and the dye is instilled into the urinary bladder, methylene blue or indigo carmine dye. So if there is ureteric injury, the uppermost swab will be wet, but it will not be stained with dye. If there is vesico-vaginal fistula, the middle swab will be stained with dye. The upper swab will be free. And then if there is just urinary incontinence, it is the lowermost swab that may be stained with dye. So apart from this, cystoscopy can be done, and this will determine which site is affected, because during the cystoscopy, there will be spots of urine from the normal functioning ureter, from the orifice, ureteric orifice of the normal ureter, while the other one, there may not be spots of urine. Then a ureteric catheter can be passed, which will now will not pass through the point of the injury. It will be stuck at the point of the injury. That will also guide the diagnosis. Then investigation like expiratory urography, intravenous urogram can be done. This will confirm the site of the fistula, and then it can also show other the normal ureter on the contralateral side. So this is the film, the CT urogram, showing the left side that is normal, showing excretion of dye from the pelvic calycial, from the pelvis, renal pelvis to the ureter down to the urinary bladder. But on the right side, there is discontinuity of the ureter at the middle portion, and then there is extravasation of dye on that side. That shows the point at which the ureter is injured. It can also help in the diagnosis. Then other investigations like renal ultrasound scan can be done, which is non-invasive, and it can pick presence of hydronephrosis, and it can also show retroperitoneal collection of urine, known as urinoma. Then other investigations like computerized tomography can be done, and then magnetic resonance imaging can also help, especially those that have allergy to dye. By way of treatment, multidisciplinary team is necessary for this management. Not only the gynecologists, specialists in urogynecology are the leading member of this team. Then urologists will be involved as well, and then interventional radiologists, general surgeon, nephrologists, and plastic surgeon may be involved in this treatment. The most important thing to note is that the interval from between injury and repair is very, very important in the recovery of this patient. It has been said that the venial sin is to injure the ureter, but the mortal sin and the mortal sin is failure to recognize it. So it is important for early recognition of injury to ureter. Ureter can be injured because of all the risk factors we have highlighted earlier. However, it is important that the surgeon is careful enough to be able to identify if ureter has been injured before closing up the patient. So the treatment to successful repair is predicated on the time of recognition of this injury, the type of injury, location and the extent of the ureteric damage, the general condition of the patient, the state of the other kidney and ureter is also important, and then other comorbidities in the patient are important in the successful treatment of this patient. The principles of treatment generally include resuscitation. Depending on when the patient presents, patient may need some resuscitation, patient may be septic, patient may be anuric, azotemic, and so the patient may be anemic and will need resuscitation. As highlighted earlier, multidisciplinary team is involved, and the appropriate treatment modality should be instituted depending on what the nature of the injury is. Then it is important for ureter to be mobilized adequately, and the anastomosis should be tension-free. And then spatulation is also important, is necessary to aid repair. Watertight closure is key, and use of absorbable suture, fine suture is necessary. Then there may be need for ureteric stent to enhance patency of the ureter even after the surgery to prevent stricture. And then there may be need for passage of drain, passive drain, to drain the anastomotic site, because there's need for the anastomotic site to be dry in case of any leakage, so that there will not be accumulation of fluid and infection and that will damage the repair. There's also, it's very important not to damage the ureteric sheath because the blood vessels run there. So we said earlier that intraoperative discovery of the injury is very important and is necessary for proper recovery, for healing and recovery of this patient to prevent morbidities and mortality as the case may be. So ureter, visualizing peristalsis is inadequate to exclude occlusion or extravasation. So other things may be necessary in this intraoperative treatment or intraoperative attempt to discover or to diagnose ureteric injury. A dye, indigo carmine dye, can be injected intravenously, and this can extravasate at the operation site within 3 to 5 minutes. Or we can see the dye in the urinary bladder if the ureter is intact. Then there can also be need to inject a dye, intraureteric injection of a dye. Look for the proximal ureter and inject the dye, and then it may leak at the site of the injury, or if there is obstruction, we may be able to see swelling around the site of the injury. Then intraoperative cystoscopy is also very important. This can confirm urinary efflux from a normal site, and then the site that is injured, there will be obviously no jet or spot of urine from that side. That will confirm that definitely ureter is injured and treatment can be offered intraoperatively. If detection of injuries within 5 days, operation can be done immediately. So in case it was not discovered post-operatively, within 5 days, if diagnosis is made, surgery can be offered immediately, and often there is good outcome. However, after 5 days, due to tissue edema, inflammation, this makes repair very difficult, and so surgery is delayed for the period of about 6 to 8 weeks. So as said, the patient may need resuscitation depending on the mode of presentation, and there may also be need for diversion of urine through percutaneous nephrostomy to divert the urine, and then so that the patient's condition can improve pending when surgery will be done in a later time. So depending on the nature of the injury to the ureter, the treatment varies. For ureteric sheath denudation, there is usually no intervention, except if the long segment is involved. Then a ureteric stent can be placed in place and removed after 6 weeks, so that the ureter will have healed by that time. Crushing, for ureteral crushing, if it is discovered intraoperative, clamp should be removed immediately, and then the viability of the ureter should be observed, and then the stent can be put if the nature of the injury is extensive. For kinking, due to suture incorporation, the suture should be removed immediately, and the same thing for ligation. Then for partial ureteral transection, fine suture, 5-0 absorbable suture can be used to repair primarily, and the principle of management should still be maintained. The avoid tension and then spatulation, avoid tension and then repair should be done with fine sutures. Then for transection, it depends on whether the upper part of the ureter, the middle part of the ureter, or the lower aspect is involved, as we can see from this diagram. If it is the upper aspect of the ureter involved in the transection, direct anastomosis, ureterostomy, can be performed with the principle still maintained. And if the damage is extensive, then transureterostomy can be done, in which the affected ureter is anastomosed to the contralateral ureter, especially if the damage is extensive. The transection, the segment that is lost is extensive. Then in the middle aspect of the ureter, direct ureterostomy can also be done. And then transureterostomy can also be done in this aspect. And then in the lower portion, we can have ureteric implantation known as ureteroneocystostomy, in which the ureter is reimplanted into the urinary bladder. This is the picture of how ureteric injury, ureteric anastomosis can be done. You can see the spatulation there, and then how it is repaired with a stent in situ, repaired over a stent, and then for the lower portion of the ureter, if the injury involves extensive portion of the ureter up to the magnitude of 10 centimeter ureteric loss, then a Boaris flap can be performed, in which the ureter is mobilized and anchored to the psoas major muscle fascia, and then ureter is reimplanted into the bladder. Then there's also room for ileal interposition, especially if the segment of the ureter that is lost is much. Ileum can be resected and interposed between the segment of the ureter. That has also been done. Then if depending on the site, the contralateral kidney, if it is compromised, then renal autotransplantation, in which the kidney can be autotransplanted lower down to connect with the urinary bladder, can be done. These are some of the pictures. Then prevention. Prevention can be primary, secondary, or tertiary. As we have said earlier, this prevention begins preoperatively with careful patient evaluation, with recognition of the high risk of ureteric injury, depending on the surgery that the patient is going to undertake. So pre-operative expiratory urogram can be done. This to evaluate the kidney location, because sometimes patient can have ectopic kidneys, and without pre-operative evaluation, the surgeon may encounter the ureter in his way, and then may inadvertently injure the ureter. Then it is important when pelvic lymphadenopectomy is being done that this evaluation should be done through intravenous urography or CT urography can be done. And it has been shown that this pre-operative evaluation may not necessarily prevent ureteric injury, because as we said earlier, the ureter runs a long course and is usually hidden. However, this can be helpful in detecting when ureter is injured, especially placement of stents. This is about placement of stents. Sometimes before, depending on the complexity of the surgery, a ureteric stent can be placed before the surgery. So if ureter is injured, the stent can easily be able to be detected, and then it will be obvious that ureter has been injured. So sometimes this stent can help in the palpation. When you palpate and feel the hard structure, it may tell you that that is the ureter, because sometimes due to hemorrhage, ureter may not be easily seen, and before the surgeon knows, it is damaged already. So the surgeon must constantly and unequivocally know where the ureter is located at all times. This is very important. It is also most important way to prevent ureteric injury. It is also important to stay outside the adventitious sheath when dissecting the ureter, not to damage the blood supply to the ureter. When using instruments that transmit energy to the tissues, the surgeon should also know the zone of thermal injury, especially when electrocoagulation is being done or laser is being used during the surgery. It has been known that the mean distance for thermal damage with most of the instrument is 2 to 5 millimeters. So anything outside within 2 to 5 millimeters close to the ureter should be avoided. Then light optic ureteral catheters have also been used pre-operatively inserted so that as the surgery is going on, that fiber-active optic ureter emits light that will show the surgeon where the ureter is located. So for primary prevention at surgery, good light source, adequate exposure, careful clamping, and adequate hemostasis and meticulous dissection will help. Some preventive strategies during total abdominal hysterectomy, which is the commonest surgery where ureter is injured, include the following: upward traction of the uterus during placement of clamps. Then the second clamp should always be applied medial to the first clamp, and the clamping infundibulopelvic ligament near the ovary after dissection and palpation should be done. Then skeletonize the uterine artery and the clamp and ligate the vessel close to the uterus, because clamping should be clamping close to the uterus immediately along the cervix is very important to prevent ureteric injury. Then during the clamping of the cardinal, uterus should also be elevated during the clamping of the uterosacral and the cardinal ligaments. Then these are some of the preventive strategies during vaginal hysterectomy. As we know, it's not ureter is not commonly injured during vaginal hysterectomy. So for secondary prevention, this is early diagnosis and identification of ureteric injury. This is important, and this involves intraoperative recognition of damage to the ureter, so that attempts can be made to repair it immediately. Tertiary prevention also is important for early recognition of early diagnosis, because this can lead to urinoma, can lead to sepsis, and then can lead to renal loss. So tertiary prevention, if it is missed at intraoperatively, it is missed, primary prevention fail, intraoperative measures fail, then tertiary prevention should not fail. We should endeavor to make diagnosis early based on some of those signs and symptoms that have been highlighted earlier. So we quickly look at, due to want on time, we quickly look at bladder injuries. So we all know urinary bladder is the urological organ most often injured during obstetric and gynecological operations, especially during cesarean section. Bladder can be injured, especially when the bladder is distended in obstructed labor, and during laparoscopic surgery, during entry with various needle or trocar entry, bladder can also be injured in such circumstances, or when there is adhesions involving, when there are previous surgeries, bladder is often adhered to the anterior wall of the uterus. So during dissection, the bladder can easily be encountered in such situations. So it's more frequent than ureteric injury, and the rate is 1 to 1.8%. So this occurs mostly during separation of the urinary bladder from the lower segment of the uterus in patients with previous surgeries. So primary repair during operation, it has excellent result, and this is usually what it is being done. These are some of the incidents of bladder injuries in gynecological and obstetric procedure. You know that bladder is most usually injured from blunt abdominal trauma, especially the intraperitoneal aspect of the bladder, and then the retroperitoneal aspect is mostly injured during in trauma from pelvic fractures. So those are conditions in which bladder is commonly injured. However, in gynecological and obstetric surgeries, bladder is commonly encountered and is injured. So it's usually said that bladder is a forgiving organ. So when injured and discovered intraoperative and primarily repaired, the healing is excellent and the bladder does well. So look, Classification, location of the bladder injury is important to guide further management. It could be intraperitoneal or extraperitoneal, or it could even be combined. Intraperitoneal injury is when the injury occurs around the dome of the bladder. When there is extravasation of urine, it goes into the peritoneal cavity, and then the extraperitoneal aspect of the bladder injury is when the other part of the bladder, like the trigone and other part, is injured, and when there is extravasation, it goes into the tissues. So signs of external ureteric iatrogenic bladder injury include extravasation of urine, visible laceration, clear fluid in the surgical film, and then in this case, urethral catheter may be seen, or even the bladder balloon, the blood balloon of the urethral catheter can be seen easily, and that usually gives away the diagnosis at this point. In laparoscopic surgery, there can be blood or gas in the urine bag. So intraoperative detection is very important. Inspection is the most reliable method of assessing bladder integrity. Large injuries can easily be detected when the while small tears may not be detected. But however, intravesical installation of methylene blue dye can also give away the diagnosis. Then cystoscopy can also be done to see, it will be able to locate where the injury is. And it can also localize the lesion in relation to the position of the trigone and the ureteric orifices. This is very important. And then lack of bladder distension during cystoscopy. When bladder is injured, bladder will not be distended because the fluid, irrigation fluid, will usually spill into through the point of ureteric injury. So management of bladder injuries, uncomplicated extraperitoneal injuries, clinical observation, continuous bladder drainage, and antibiotics is usually sufficient to take care of extraperitoneal injury, because there's less mobility in that area. When the bladder is rested, the walls usually come together and healing is excellent. However, complicated extraperitoneal injuries with symptomatic extravasation of urine, then exploration and drainage and repair can be done. For intraperitoneal injuries, surgical exploration is very important with repair, double layer closure with absorbable suture, and then Foley catheter drainage is usually sufficient for this type of injury. Then prevention of bladder injury is usually routine drainage of urinary bladder is very important before surgery. It collapses the bladder and brings bladder out of harm's way, especially when one is, especially in obstetrics surgery like obstructed labor. It's good to drain the bladder before entry so that the bladder will not be in your way as you enter. And a careful entry into the abdominal cavity is also very important, especially during laparoscopic surgeries. Various bladder drainage before various needle introduction is also very important. Then,
Doctor, you have 5 minutes.
Thank you,
to round your presentation.
All right, thank you. Then meticulous and careful sharp dissection in the presence of adhesions, endometriosis, or previous lower segment cesarean section is very important to remove the bladder from the anterior, from the lower uterine segment before other surgeries can be performed. Then it's very important to be careful with cautery while and then while suturing, because sometimes during the surgery, bladder may not be injured, but when one is suturing, one can pick the bladder and anchor it to one structure or the other, or to anterior abdominal. Before you know it, fistula can develop from that. So post-operative care involves what, for all these conditions, post-operative care is very important. Stent is usually removed after 2 to 6 weeks. If ureteric stent is placed, it should not be left. However, it may be left longer if there is irradiation of the pelvic fibrosis. Abdominal drain is usually removed when the drain is effluent is less than 25 minutes in 24 hours. And the urethral catheter is removed depending on the complexity of the surgery that was carried out, 7 to 10 days, in some cases up to 14 days. And then post-repair intravenous urography can also be done, or CT urogram can be done to check the integrity of the repair, because sometimes there can be progressive narrowing of the ureter after surgery. So, and then that may eventually lead to obstruction and renal damage. So, post-operative evaluation with intravenous urography can be done. So, to conclude this presentation, this long, lengthy presentation, we say that iatrogenic urological injuries can be prevented by adequate pre-operative assessment, good surgical technique, and visualization of the bladder and ureter. Anticipation and high index of suspicion, early urological referral, and appropriate investigation of suspected urologic injury is of paramount importance. This is to avert damage, ureteric damage, and renal damage, and then loss of renal function in the patient subsequently. And every surgeon that performs an abdominopelvic surgery should be conversant with the anatomy of the ureter, as that may be the saving grace during gynecological surgeries. Thank you all for listening. These are some of my references. Thank you.
All right, thank you, Sambo, for this lucid and educative presentation on urologic injuries in gynaecologic surgeries. I believe our members have been enlightened, and it is time we come to questions for comment. Send your message on the chat, or you can raise your hand if you want to speak. Okay, so the floor is open for question and answer now. No hand has been raised, and since there's no question too, so it's either the presentation is so straightforward and well understood, or Dr. Sambo has succeeded in confusing us that we don't even know what to ask. I believe his presentation was very clear, and we've been educated well enough that we don't need to ask any question. Let me still check if there's any hand raised. Okay, Dr. Nkata hand is raised. Can you go ahead and ask your question, sir? Dr. Nkata, your hand is raised. Go ahead. You can unmute yourself. Okay, so maybe we are having issue with Dr. Kanta, who has raised his hand to talk, but it's not currently available, and there's no any question on the chat box. Yeah, so we move to the next presentation. The next presentation will be taken by WHO, and Dr. Emmanuel Okeke will be taking the presentation on behalf of the state coordinator, Dr. Bello Ahmed, and he's going to take us on the topic title Integrated Immunization Campaign as Health System Strengthening Tools. Clinical and public health lesson from the 2025 Measles-Rubella campaign in Taraba State. Dr. Okeke, if you are with us, please, the time is up for you. You can go ahead and start your presentation.
All right, thank you so much. Thank you so much, the moderator. Thank you. Please, can I be given access to share my screen?
Yeah, go ahead. I think the slides also available.
Okay. Can I share my screen now? Can you hear me? Please confirm you can hear me, please. Hello, can you hear me?
Yes,
We can hear you.
Okay, great. Please, can you see my screen? Can you see my screen?
Yes, Doc, we can see it. We can see it.
Oh, okay, all right. Okay, thank
your
you so much.
screen.
Yeah, thank you so much. My name is Dr. Keke Manuel. I will be making this presentation on behalf of my state coordinator, Dr. Ahmed Bello, who I guess is also in this meeting. So he gave me the go ahead to make the presentation on his behalf. Okay, so this is on integrated immunization campaigns as health systems threatening to the clinical and public health lessons from 2025 Measles-Rubella campaign in Taraba State. Okay, so this is the outline of the presentation. All right. So as a way of introduction, Nigeria continues to carry a disproportionate high burden of vaccine-preventable diseases, particularly measles, rubella, and polio viruses, among others. So in 2024 alone, all the 36 state plus FCT reported measles outbreak, which highlights persistent immunity gap despite decades of routine immunization. Rubella, though less visible, poses a serious but silent threat, particularly through congenital rubella syndrome, which results in preventable congenital anomalies. Historically, rubella has been underdiagnosed and often misclassified as measles. So this is the burden of vaccine-preventable diseases. So highlighting measles, rubella, poliomyelitis. So for measles, we frequently have periodic outbreaks, and we all know that measles is high transmissible and major contributor to childhood mortality. Then for rubella, we already know the CRS, which is congenital rubella syndrome. Then this can also be prevented through MR vaccine. And like I said before, it is often underdiagnosed. For poliomyelitis, we are still dealing with risk of circulating variant of virus outbreaks, which is prevailing in the northwest and then part of northeast. So, community. Why integrated campaigns? Why is it necessary for integrated campaign? This will help go a long way to increase vaccination coverage. Of course, reach the zero-dose children, strengthen routine immunization, improve surveillance, and build resilient health system. So we should know that integrated campaigns today will in turn give a healthier generation tomorrow. Then the 2025 Measles-Rubella campaign marked a strategic shift from the usual measles-only control to integrated measles, rubella, polio, HPV, and RI service delivery. So this presentation examines how the Taraba State experience demonstrates that immunization campaign, when properly integrated, can serve as powerful health system strengthening tools, not merely short-term disease control exercises. Then for over decades, over 2 decades, Nigeria's public health response has relied heavily on vertical disease-specific campaigns. Like we usually know, we do polio campaign, measles campaign, NTD, malaria, etc., and it is often planned and implemented in isolation. So it's usually done as a standalone. So we know this approach has resulted in, so because many times malaria might be doing their campaign, polio is also ongoing, and all of these activities are supposed to be carried out by the same health worker. So it usually leads to repeated disruption of routine services, health worker fatigue, parallel logistics, data system, and financial streams. And of course, it usually leads to fragmented accountability. The 2025 Measles-Rubella campaign was deliberately designed as integrated platform, aligning with Nigeria's collaborative action strategy, sector-wide approach reform, which is SWAP, MPA-CDA priorities on efficiency and sustainability. Integration was not just operational, it was strategic, aiming to reduce system strain while expanding impact. So you look at the visual at the right side, so you can see the Nigerian journey to integrated immunization, from vertical program to stronger health systems. So we hope that this strategy, new initiative, will be sustained. So you can see we have ranged from routine EPI, which of course was the foundation of immunization, through continuous service delivery at health facilities. Then we move to vertical SIAs like measles, supplemental immunization activity targeting specific diseases. Then polio campaigns, intensify polio vaccination rounds to interrupt polio virus transmission. So we have now migrated down now to integrated MR plus NOPV2. So then, of course, going further, we also included the MR, HPV, and RI. And all of this is targeted to health system strengthening, building resilient system for sustained immunization, better data surveillance, workforce, and community trust. So stronger integration, of course, will also lead to higher coverage and a healthier nation. Then the overview of 2025 integrated MR campaign in Taraba State. Taraba State implemented the integrated MR campaign from the 18th to 27th October 2025, which is a a 10 days long campaign, and including the 2 days mop-up. And this was done in all the 16 LGAs. So there are key features to take note of. So the target population was, for MR, was 9 months to 14 years age. Then the polio, which is NOPV type 2, was for 0 to 59 months. The HPV was given to 9-year-old girls. Now, this was a scale of, and of course, it is worthy of note to bring to your notice that this is the largest in the history. In fact, what Nigeria did last year has never been done in many nations. So many nations, we are looking out to see what the outcome will be. So the target population was 1.6 million children. Then the delivery strategy that was used was fixed strategy, temporarily community post, which is targeting schools, markets, worship centers. Then also we have the third one, which is house-to-house sweep teams, right? Going back to the houses to also reach out to those who have been missed by the fixed and the temporary post. The campaign was implemented with the technical support from WHO, UNICEF, AFINET, IVAC, eHealth Africa, and others. But of course, with strong state-level ownership and coordination. So this is the campaign summary dashboard. So 16 LGA were reached. 168 wards were reached. 4,764 settlements were also reached. Then the target, like I've said before, 1.65 million. And the MR campaign vaccinated 1.71 million children with the MR vaccine, giving us 104% coverage. For the NOPV type 2, 930 plus were vaccinated. For HPV girls, we also vaccinated with 27 plus we are also vaccinated. So looking at the administrative coverage by antigen, so you can see MR 104, NOPV type 2, 81%. Then the coverage, the vaccination output by antigen, like I've said before, this is just the chart. So like I said, the integrated campaign successfully delivered 1.71 million MR doses, 930 plus NOPV doses, and 27,000 plus eligible girls were reached with HPV vaccine. Sorry, it seems this thing is frozen. Okay, fine. All right, so still looking at the MR administrative coverage by LGA. You can see that the highest administrative coverage was Jalingo, which is 129%. The lowest is Karim Lamido, 93%. So in summary, no LGA went below 90%. Most LGA achieved or exceeded the 95% target, indicating broad campaign success with localized areas requiring further review. So you can see it's only Karim Lamido that didn't meet the target. Okay, so Beyond vaccination numbers, so looking at the health system strengthening intervention, the campaign strengthening core PSC functions. And what are these? The first one, strengthening routine immunization. We all know that routine immunization is the primary gateway to PSC. All right, so RI antigens were delivered alongside campaign vaccines. Missed children were identified and linked back to RI services. Campaign messaging reinforced RI schedules and completion. Then the second one is addressing zero dose and under-immunized populations. So they had to reach settlements, nomadic routes, and border communities were deliberately prioritized. Integration reduces missed opportunities for multiple antigens. So the next one is expanding adolescent health services. HPV, like we've said before, vaccination was successfully delivered through school and community platform. This demonstrated the feasibility of adolescent-focused services within the PSC frameworks. Now, of course, we know that from what we have noticed, most of these adolescents, which is the girl child at the age of 9, they rarely go to the PSC. But this campaign has also provided the opportunity to strengthen that function of the PSC in reaching even the adolescents. All right, so the clinical governance and quality of care during the mass campaign. There was pre-vaccination screening. We recorded one serious AEFI involving a 6-week-old infant who was vaccinated while already ill. So ideally, the team should have known that that the child being ill should have a bit delayed this the giving of this antigen. So, and this underscoring the need for clinical vigilance, adherence to eligibility screening protocols. So the next one is the AEFI surveillance and management. 341 non-serious AEFI and 2 serious AEFI were reported. The referral pathway, AEFI kits, and clinician engagement were critical. So, of course, in the course of this, the pre-implementation activities, the clinicians from general hospitals and were actually trained and engaged. And I think also we also have somebody from a clinician from FMC and including specialists. We are engaged to be able to handle AEFI cases when reported. Transparent reporting helped preserve public trust. This highlights the essential role of doctors in supervising, mentoring, and enforcing clinical standards, even in campaign settings. We look at the data, digital tools, and evidence-based decision-making. The campaign leveraged digital public health tools to enhance accountability. The GIS supported micro-planning to map the settlement and facility were utilized. Vaccination team tracking using GTS to verify physical reach. The ODK-based data collection for real-time reporting, digital dashboard for daily performance monitoring. There was also daily evening review meetings, and which function like the clinical audit meetings that we usually see in the clinical settings, morbidity and mortality reviews, real-time quality improvement sessions. So this provided opportunity to be able to have an insight on the real-time challenges and then offer solution to them. So these tools enabled rapid course correction and data-driven leadership. In terms of equity access and service delivery in hard-to-reach settings, equity was a defining feature of Taraba campaign. 989 hard-to-reach settlements and 244 insecure settlements were targeted. Additional teams and logistics were deployed to fragile area. Collaboration with security agencies enables safe access. It is worthy of note that in the course of this, there was no serious injury or attack to the vaccination team that were involved in this campaign. This experience reinforces that universal health coverage cannot be achieved without deliberate strategies for marginalized populations, even when operational costs are higher. And looking at the financing, sustainability, and system ownership, financing remained a critical bottleneck. The Taraba State government released 100 million counterpart funding, mainly for coordination and supervision. However, it is also worthy of note that the core operational costs remain largely donor-funded. LGA counterpart funding was minimal or absent. This exposes a sustainability risk. Campaigns succeed today, but long-term resilience depends on domestic financing. Physicians, through NMA and policy advocacy, must push for dedicated immunization budget lines, timely release of counterpart funds, financial accountability mechanism. It's also worthy of note that the counterpart fund was released late, few days to the end of the campaign. So the role of medical professionals beyond the clinic. Doctors played pivotal roles beyond clinical service delivery. We also have the doctors' advocacy to political, traditional, and religious leaders. We also done, and the media engagement to counter misinformation. Some of these rumors and myths, misinformations, we best the masses. We really take it to heart, especially when it is coming from professionals, which are doctors. Support to AEFI management and, of course, referral system. The Taraba experience reinforces that doctors remain the most trusted voices in vaccination, particularly in times of hesitancy and misinformation. There are a handful of key lessons and implications for policy and practice. We looked at what worked. The first thing here is the integrated planning and delivery, strong coordination structures, digital monitoring and daily reviews, community and political engagement. What do we need to strengthen? The pre-vaccination clinical screening. Like I said, we recorded a very serious AEFI. Vaccine was given to a child 6 weeks who was already ill. And of course, that child was lost. We lost the child. Then state and LGA financing ownership, workforce numbers, and workload balance. The policy implication, integrated campaign should be institutionalized as extension of PSC, not emergency standalone events. As a way of conclusion and call to action, the 2025 Taraba Integrated MR campaign demonstrates that when immunization campaigns are intentionally designed, they do more than prevent disease. They strengthen
Dr. KK, we can't hear you. You've gone off. Please, can you log in back so that we can conclude on your presentation?
Okay, sorry. Sorry, my system, I did not know my system was down, and I don't have access to power, but I will just conclude. But I think I'm almost done. I'm almost done. So I'm at the conclusion and call to action. Yeah, the 2025 integrated MR demonstrate that when immunization campaigns are intentional design, they do more than prevent disease. They strengthen the system. The call to action for the NMA members, number one is to champion immunization as a core clinical responsibility, advocate for sustainable PSC financing, support data-driven quality improvement. Then, of course, lead public trust and the ethical practice. So the future of disease elimination in Nigeria depends not just on vaccines, but on how well our health system delivers them. Thank you. Sorry for the technical challenges. Thank you, and over from my end.
All right, thank you, Dr. Okeke, on behalf of WHO for the lecture on integrated immunization campaigns, the experience of Taraba State Measles-Rubella, during the 2025 campaign. We'll open the floor for question if there's any. Let me see on the chat box. Okay, I can't see any message on the chat box. Let me see if anybody has raised his hand. Okay, so yeah, so no question, but I have a question for you, Dr. Okeke. Are we together?
Yes, I'm with you, sir.
Okay, yeah. So my first question or comment now is about from the beginning of your presentation, you actually noted that rubella is commonly missed. And you've made a mention that sometimes it resembles measles. A few experience here in FMC, most of the measles cases that we call the state disease surveillance officer to take sample to probably be able to get us whether it is measles or rubella. We don't get actually any reports that this is rubella or this is measles. So at your own end at WHO, do we actually have a confirmed case of rubella from the samples that have been taken for all the suspected measles that have been admitted across the states? Do we have a confirmed case of rubella as a diagnosis? That's number one. Number two, looking at your antigen delivery too on one of the, I can't remember the slide number, I saw that HPV was clearly visible on the bar chart. And I remember when it was rolled out, somehow it's like Taraba was 100%. But I think a few months ago, we went on community engagement in some places, and we asked a group of women who actually come out to say they don't want HPV to be given to their children, they are not interested, and so. So after this campaign strategy, do we actually have information about what is the intake of this HPV vaccine? We know how important it is. present cervical, possible long-time cervical cancer in girls. But this year, the few that we have interacted in, we have a group that will go out to actually discuss and find out and trying to enlighten people. What has been the effect of this HPV after those campaign periods? Do we have record about truly our people are actually taking it, or after the campaign, everything and everybody has gone to sleep? Thank you.
All right, thank you so much. Thank you, sir. Okay, for the first question, yes, in terms of rubella, there are few rubella detected from the measles cases collected, tested, or even though I don't have this record at this moment. You know, like we know, rubella is milder compared to measles. That the major challenge for rubella, which is of a great concern, is the fact that it causes congenital rubella syndrome. That's actually the major concern. So then for the issue of HPV uptake, yes, there have been some level of improvement, but still not adequate in terms of uptake. And when I say uptake, where mothers take their 9-year-old child to the facility to receive it. So, but the only strategy the state have deployed is strategies that target the schools, because it's usually in the primary school that we have this age group, the 9-year-old girls. So a handful of activity have also been done targeting the schools to reach out to the 9-year-old girls. But like I said, the improvement is not yet adequate. We still have some number of mothers now taking their children to facilities. But like I said, it is not yet, we have not really reached where we are supposed to be. But we hope with intensify and continuous sensitization and awareness, this will definitely improve in the long run. Thank you. I don't know if I've been able to answer your questions.
Yeah, thank you very much. Thank you for the response too. Let me still check our this. If there's anybody that has raised his hand to make comments, I can't see any. Let me still go through our chat. I've not seen any question or comment too. Yeah, so thank you, Dr. Okeke, and thank you, WHO. Help us thank your state coordinator for coming to enlighten us. There's something that, okay, so there's a question for you, Dr. Okeke, that just dropped now. Are you there?
Yeah, I'm with you, sir.
Yeah, so the question on the chat says, where can children 9 to 13 years get the HPV vaccine? So is it available everywhere? Where specific can people go for it?
All right, thank you so much. Okay, currently this vaccine is no more given to children beyond 9 years. The reason because the available vaccines are not adequate. If you remember, in 2023 there was the introduction campaign that was done for the HPV, and that campaign targeted 9 to 14 years old children. This is to be able to catch up with those who have gone above 9 years. Now, because of inadequate vaccine, this has been streamlined to 9 years. So as it is, which is of course has been routinized, is supposed to target the 9-year girls. All right. So the vaccines are no more available for any children beyond 9 years. So what we should be doing, what we are now targeting, is that any child that is clocking 9 years should get it. So children coming up there is vaccine for them on a regular basis. And this vaccine is available at the primary healthcare centers. And also, you can also get this vaccine in the secondary facilities like the General Hospital, even specialists. And of course, it's available at the tertiary institution, the FMC in Jalingo. Thank you.
All right, thank you. So I hope the person that the question has gotten the response, and every other person that wants to know is available. It's part of the routine immunization. So wherever there's routine immunization in primary health care, in the state, cottage hospital, referral hospital, specialist hospital, you will get the vaccine. So thank you. I think I can't see any other question again. So I think it's a call. You made very important points about, call to action. Nma, you call on Nma to advocate for early release of counterpart funds and those other issues, political and legal issues. I think it's good because some of these things, if you are outside politics, you find it very difficult to inform when some of the things that are happening that is affecting health today. And so part of the encouragement that we say is for our people to actually join politics. And when they're in politics, they would probably understand this action that they are actually calling on NMA members to advocate for. They will know the benefit of early release of funds. They will know the need for legislation, related to health, and probably will be able to get this thing better. People don't have such knowledge, will not actually see the benefit of the need for counterfund funds for health issues because it's not displayed on the road. Nobody is seeing when it's passing. But as health practitioners, for doctors, if they join politics, they head committees on health, they will be able to influence a lot of policy. So I call on all of us who are politically inclined, even those who are not inclined, we encourage people to join politics. And let us also come out to support our colleagues who are interested, in joining politics. I'm not campaigning for anybody now, but I learned to have the base of my knowledge about 3 doctors that I'm aware of now who are actively campaigning, to join our states and national legislative section. So let's support them and see that they succeed. And hopefully, they will be able to do, the necessary thing to make life better for us and for the patients we are taking care of. So thank you, Dr. Okeke, once again, and thank you, WHO.
Thank you, sir. My pleasure.
Yeah. So our next presentation will be taken by Dr. Ishaku Hassan. Dr. Ishaku Hassan is a pediatrician working with Federal Medical Center, Jalingo. I hope he has joined us. And he is going to take us on the topic. Let me see if I can get this topic clear. Yeah, so
hello.
Yeah, so he's going to take us on.
Hello.
Yes, we can hear you.
Okay, so thank you very much. Sorry, my camera is not accessible. I don't know whether it is from the ICT, the camera. But
okay.
I don't actually need it.
Yeah, you just unlock your Zoom video on your system. I think you appear.
Okay. Okay. I think I will just present like that.
Okay, no problem. If we can hear you, so you can go ahead. So Dr. Ishaku is taking us on psychosocial issues and family dynamics in sickle cell disease. So let's listen carefully. Sickle cell is very common in our environment, and we know not just the medical issue, but we are looking at the psychosocial issues and family dynamics. Very interesting topic. So Dr. Ishaku, the floor is for you now. You can start your presentation.
All right. So good evening, everyone. Thank you for this great opportunity to share this little talk on the psychosocial issues and family dynamics in sickle cell disease. All right, as already, okay, so this will be our outline. It's been a very long day, so I will try to make it short. Okay, so next slide. So basically, by way of introduction, sickle cell disease is the most common genetic disorder among Blacks. It poses a significant psychological burden, not only on the sufferer, but also on the caregivers and their families. The level of support given to the sickle cell children may reflect the dynamics of intra-family relationships and the emotional state of the family members as well. And so the impact on the family is worse in developing countries such as Nigeria because of inadequate social welfare and healthcare services that is made available to us. Okay, next slide. So worldwide, it's been recorded that about 7% of the world population carries the sickle cell gene. And in Nigeria, which is the most populous nation in Africa, it has the largest burden worldwide as well. About 25% of Nigerians are estimated to carry the sickle cell gene, and about 2 to 3% of children born annually have the sickle cell disease, not just the gene. Now, over 150,000 children are born annually in Nigeria, and this is as against 2,500 obtainable in the United States. That can actually also be seen to have the effect with the large population and what resources is made available for this large number of patients. Now, those living with sickle cell disease in the United States are estimated to be 100,000, and this is opposite to over 1 million individuals with sickle cell disease in Nigeria. Okay. Next slide. Now, what is sickle cell disease itself? Basically, it is the inheritance of two abnormal hemoglobin genes, one of which must be hemoglobin S. And the commonest form is what is known as the sickle cell anemia. That is the homozygous inheritance now of the hemoglobin S gene. That means an individual has inherited hemoglobin SS. That is sickle cell disease, sickle cell anemia, sorry. Then other forms of sickle cell disease that are also more prevalent also, the sickle cell HBSC, and then sickle cell thalassemia. All right, next. Okay, so the variants and their frequencies commonly to us is the hemoglobin S, and this exceeds usually between the range of 20 to 40% in parts of Africa. It is also found in the Mediterranean, Turkey, Iran, Saudi Arabia, and India. Commonly is within these borders. Hemoglobin E, not so common within our own geographical location. It is more common in the southeast of Asia. Whereas hemoglobin C is predominantly found in the Côte d'Ivoire region. The further you go to the west in Africa, the more the prevalence of hemoglobin S is found. In fact, as you are coming to the east, you just see that it's continuously decreases. For instance, it is more prevalent in Ghana as compared to Nigeria, because Ghana is west to Nigeria. Likewise, even in Nigeria, hemoglobin C prevalence is more commoner among the west, that is the Yoruba land, compared to those of us in the northeast. So that's how the prevalence of hemoglobin C is also noticed to be there. It is related with generally hemoglobin S, or the variants of the hemoglobin deficiency generally is with the Plasmodium falciparum. So where you tend to have Plasmodium falciparum is in attempt actually to increase the survival. So that is what is known as polymorphism. Next slide. Next slide. Hello. Hello.
The slide is
Hello.
moving. The slide is moving. Maybe it's not moving on your side.
Okay. All right, fine. I've seen it now. So the previous slide that it just showed the geographical diagrammatic representation of what we have already talked about, where you have predominantly the hemoglobin S, hemoglobin C, and E variants. Okay, so next. So basically, the clinical burden now of sickle cell disease, it can come in various forms, and it can actually affect the individual who has the sickle cell disease or the family members, as well as even those that also are involved in the care of an individual that has sickle cell disease. So what are those things that contributes to the burden? Now, sickle cell sufferers, they face severe clinical challenges, and this can actually range from recurrent nature of the illness, which is in most cases is not predictable. And the brain also, which is very prominent feature in sickle cell disease, can be lifelong and influencing cognitive function, also affecting psychological impact on the individual as well as their families. The fact that this individual has to attend clinic at a regular intervals, it's also a major challenge, and repeated hospitalizations. Likewise, the need for recurrent blood transfusions. In fact, some, they will tell you that they don't know anybody to call for blood transfusion again, because they have virtually received blood from every of their neighbor, every of their church member that they are of the same blood group. So they don't know who else to call. So these are the kind of challenges that they can actually suffer. The daily use of routine medication, the fact that you wake up every day and you have to take a medication for you to survive, is also a significant burden that can actually impact the life of an individual with sickle cell disease. Okay, next. Now, among the psychosocial problems that can actually be seen among individuals with sickle cell disease is depression and anxiety. This can actually is a disorder which is by far-reaching consequences. It includes the increase in pain, heightened opioid use, poor treatment adherence, interference with professional duties, schooling, interruption or absenteeism, disruption with family dynamics. All this contributes to the mental disorder that an individual with sickle cell disease suffers. Now, the common manifestation, which is depression and anxiety, about 20 to 30% of individuals with sickle cell disease are said to suffer from depression and anxiety. And this is almost 3 to 4 times higher than the general population. What generally attributes to this is because of the aforementioned challenges, the repeated painful crises, repeated hospitalizations, recurrent need for blood transfusions, and then some of the other things that we'll also be looking at. Things like poor self-image. Those with sickle cell anemia or sickle cell disease in general, they have a typical facie that it may actually present as a poor self-image. Some of them may have chronic leg ulcers, avascular necrosis of the hip, head of femur that will now result to limping, and the rest. So those are things that can actually impact the self-image of an individual with sickle cell anemia. Enuresis is something that is somehow hidden. However, it is also a common feature in subjects with sickle cell disease. The fact that they have hypostenuria, they are unable, the kidney is unable to concentrate urine, so that they now have this problem of bedwetting. It's a common entity in individuals with sickle cell disease that can actually influence part of those conditions that predispose them to having depression and anxiety, stigmatization, neurocognitive deficit. Now, in general, there's what is known as acute cerebral syndrome in individuals with sickle cell disease. However, commonly, this is what is seen to be an overt stroke. But there's what is known as occult stroke. And in this case, usually there's brain imaging with MRI, which demonstrate an area of infarct on T2 weighted MRI. But clinically, there's no focal neurological deficit. And this seems to be even more commoner than even the overt stroke that an individual with sickle cell disease will manifest with. So this will also impact on their neurocognitive capability. In the older individuals, they also suffer workplace discrimination and the rest. Okay, next. Substance abuse, especially opioid. While we know that this is a very effective pain management medication, it can also have an addictive property. It is essential to exercise caution, especially when using pentazocine. Unfortunately for us, pentazocine seems to be more commoner or readily available to use, but its use, it's actually, if not used rightly, it can actually result to addictive effect that the individual suffers dependence. And this can actually be characterized by behavioral, cognitive, and physiological phenomena that can develop with repeated use of this substance. Okay, next. Next slide. Next slide. Hello. Hello.
It has been changed, sir. It's on substance abuse continued.
Okay, I've seen it now. It has changed on my side now. Okay, thank you. So, the features of this dependence could actually manifest as a strong desire to take this medication, difficulties in controlling its use, persisting in its use despite the harmful consequences. That's the individuals now has already developed the dependence, and then the higher priority given to the drug use than other activities and obligations. There might also be an increased tolerance that individual, once you use this medication, it no longer even take care of the pain, except it at very higher dosage. And then sometimes even a physical withdrawal state could also be seen to be observed. All right, so next. So this is just a clinical photo showing the hyperpigmentation and induration on both forearms in a patient with pentazocine addiction. It can actually manifest with diverse presentation. It could be ulcers, it could be this hyperpigmentation or indurations and the rest. Okay, so next. Now, so how do we take care of this opioid dependence? Adequate assessment of each vaso-occlusive episodes is very paramount, and usually we need to have a good physical and psychosocial approach to that. Adequate education also on opioid use is very important. Now, this actually starts with the physician in general, because in most cases, it is with the healthcare worker that they always have the first encounter with the use of opiates before the dependence will now come in. So the use of that is very important. That pentazocine, as we have said earlier, it has more property of that dependence more than the other opiates available. Like morphine, it could have actually been much better, but because of cost and accessibility, it might be very challenging getting that. In fact, I just had one patient that bought 100 ml of that at 38,000 naira. You can see how costly it is. So it's not really that affordable to many families. But if at all we are going to use pentazocine, it is advocated that use of this medication, frequent dosing within a short period of time, 24, 36-hour usage, when they come in pain, to be able to quench the cycle of that pain is safer than giving them a prolonged use of 5 days on pentazocine and then widely spaced. It does not have much pain control in that aspect. Now, so adequate pain management, that is what we have said. Then always also try to differentiate between addiction and pseudo-addiction. At times, we tend to underplay the pain that the patient is actually coming with. But if we are able to use the pain scaling or rating scores, one can be able to use that and then judge appropriately whether this patient is really in pain or not. Because underestimating their pain also adds to their psychosocial issues, which is also very significant. And that is where the physician comes into that as well. Now, use of non-pharmacological approach to pain management is also important. Exploring non-opioid pain management options is significant and crucial. Now, certain conditions also, like morbid mental health issues, such as depression and anxiety that we talked of, can actually coexist with that and then present with this frequent manifestation of pain. So when such is identified, quick referral to where they can be able to get assistance is of paramount to their management. Next. Now, financial burden. Predominantly, the form of healthcare financing for us in Nigeria is out of pocket. And over 60% of families faces the catastrophic healthcare expenditure. Catastrophic healthcare expenditure here means like more than 10% of the total household income is being spent on healthcare, and or more than 40% of non-food expenditure is being spent on this healthcare. So this is actually something that it can affect so many aspects of the family and the child himself. Now, this usually comes about as a result of frequent hospitalization, the loss of man-hour that the parents are going to put while the child is on admission, or the hospital visits, job loss because of mother is always going to the hospital. She's always on admission with the child. They can actually result to job loss. Underemployment for the older individuals with sickle cell disease, we talked of stigmatization and the rest. Not so many institutions will want to employ them. So this is also part of the things that adds to the psychosocial under the financial burden. Now, because of the catastrophic nature of the healthcare expenditure with sickle cell disease, other family members may also see as if they've been neglected, and then a priority is being made towards the child that has the sickle cell disease. So this actually have also a negative impact on the family setting, and that also adds to the burden. All right, next. Interpersonal relationship with the family members. Now, in general, a diagnosis of sickle cell disease in a child, it's a bad news. And it's usually, in most cases, it's actually welcomed with a grief. And so the stages of grief usually will be seen to manifest, especially for those that either have had an experience with, either they've had a child with sickle cell disease before, or they have a relation, or they have had close encounter with an individual with sickle cell disease. Usually they are the group that will have this accept it with as a bad news. Also, there are some that the diagnosis of sickle cell anemia is actually a real shock to them, in the sense that pre-marital counseling, they were actually able to do their hemoglobin electrophoresis. Unfortunately, the health institution has contributed in failing some of the couples. As such, they are given a wrong diagnosis. As such, when such occur, it's actually going to be met with serious grief. So we need to also allow time for the grief staging, usually which starts with denial, anger, depression, bargaining before they accept finally. And this can actually take diverse duration of time depending on the individual. Others will be able to get through all the stages within a short period of time, less than 6 months. Others can actually take more than 6 months before they are able to come to reality with what is actually happening. And so feeling of guilt for some that they may be actually aware of their genotypes even before marriage, that could also be seen to be there. Financial difficulties, which we have discussed. a disruption in family interactions that can actually cause conflicts. Many actually have separated because of this diagnosis of a child with sickle cell disease. The neglect of other family members, that also because of the catastrophic nature of the health expenditure and sickle cell disease. Some parents may actually also attempt to shield their child from the social realities, leading to conflict between the adolescent and the desired independence of their autonomy. So that can also be seen in adolescents, usually by the time that they want to gain autonomy. The parents are trying to say, no, you cannot be involved in this and that. So those also create conflict. And then adolescent patients may also experience feelings of guilt as they are aware of the physical and economic impact of sickle cell disease on their own family. So the fact that the catastrophic nature of the healthcare expenditure, the child with sickle cell anemia or disease is able to now see what is actually happening. Sometimes they tend to, the older ones, they tend to now look at it and then say, everything that my parents have is being channeled to my healthcare. And so this also have an impact on that. And then in general, it will now affect the family, causing family dysfunction. Next. Okay, so interpersonal relationship with peers. Sickle cell disease for children, especially the adolescent, and this is also very common with the boys. They may not be partaking in the physical or strenuous activity, playing ball and the rest with their peers. And so their peers may tend to now label them as being lazy. But the general thing is that an individual with sickle cell disease as this chronic anemia may also be suffering from chronic fatigue and limitations, either because of the repeated pains, or they may be having avascular necrosis of the hip of head of femur and the rest. So all those things can actually make their peers to now label them as being lazy. They are also at increases of being bullied, either because in general, this group of individuals, they tend to have a lag in their growth, and so they appear to be much smaller compared to their peers. And then even also in their sexual maturity, they also tend to lag behind their peers. So all this can actually contribute. Some may always be asked, why is your eye yellow? And the rest. So those are things that also predispose them to being bullied. So leading to also low quality of life. They can also be socially isolated and limited interaction with peers. And so the knowledge and understanding of peers regarding sickle cell disease significantly influence the relationship with the sickle cell disease or disorder individuals. And so the need for a targeted interventions that combats stigma, promote positive self-image, and enhance cognitive functioning is very much welcome in the management of such interpersonal relationship. Next. Next. Okay, so dealing with the family dysfunction. Now, it's been found that families with a comprehensive understanding of the disease tend to have a better interpersonal relationship with the overall adjustment. And so it's a very clear fact that a favorable family environment has been shown to have a good prognostic index. So any family setting where understanding of the disease condition is being established, and they've been able to also accept and manage it well, the the family is actually able to pull through very easily with a better prognostic index. So families need to seek a new direction to work towards more organized family functioning regarding the psychosocial effect. Likewise, dealing with family dysfunction requires greater attention to communication between the family members. So the family members need to be carried along in counseling session. Not only the mother. Most times you see only mothers bring their child to the clinic. It shouldn't be so. Ideally, both parents will be there. And then from time to time, siblings should also be invited. And then counseling with the family members will be able to help in taking care of such dysfunctional issues. Role of each family member in the care of an individual with sickle cell disease is also very important. Emotional involvement between family members is of importance. Next. Okay, so the coping process of families and social support. Now, the coping process starts with the acceptance of the disease itself, and then, or making the diagnosis. So acceptance is very important before one can be able to forge ahead and say, okay, so what is the next step to take? And so the disease management can be made easier. So strategies include pillars of social support, which can actually involve extended family members, friends, neighbors, health professionals, pillars of health support. Now, some parents, they tend to say, okay, they don't want any other person to know that my child has sickle cell disease. In most cases, it doesn't really go well. At least, even if the person is trying to be secretive or how will I put it now? They don't want others to be aware that their own child has sickle cell disease. There are some specific individuals that cannot be shielded from such, especially the school teacher. They need to know, okay, some significant others in the family should be able to also know, and because they can actually also give certain support that the individual or the family can actually benefit from. Establishing sickle cell clubs or associations can also help in such that the participation of families of children with sickle cell disease in social organization and association of sickle cell patients strengthens rather the family, and it provides space for sharing experiences of problems that can actually be common to such families. The healthcare provider, it also plays a very important role in this case, whereby we are able to have a triage and to reduce their waiting time, and to not to underestimate their pains, and to also refer such individuals promptly. Now, with regards to reducing waiting time, a child with sickle cell crisis now comes in vaso-occlusive or whatever form, is in pains, and we're busy taking history, how did it start, and the rest. What that child actually needs at that very moment, you've already made your diagnosis, you already know. You may be thinking, okay, what could be the precipitant? But you already know that this is coming with pain. So why not abort the pain before you start asking for other things that could help you to establish the etiology or the precipitating factor to that vaso-occlusive or any form of crisis event. So those are the things that can help, because the more they wait and stay too long in the hospital before they are being attended to, it adds to the psychosocial burden that we are talking about. Next slide. Okay, so by way of recommendation, okay, is that the next slide? Okay, okay, so by recommendation, Social support should be available to alleviate caregivers and family members' burden. Provision of social welfare programs such as national health insurance for children with chronic disease, such as sickle cell disease, is going to help to reduce the catastrophic healthcare expenditure that is seen in this category of persons. To establish sickle cell clubs is also important. Limitation of family size to reduce the risk of mothers from having additional sickle cell disease children is also going to help. I have a family that they have 5 children. The order from 1st to the 5th, every child has sickle cell disease. You can see how painful that is. And in most cases, unfortunately for us, in African setting, is the mother that tends to suffer all the brunt. The father may just walk away, or they separate, or the father might just say, okay, yes, they may give the financial support for those that are supporting, and but all the admissions and the rest is the mother that shoulders that. So those are things that it can also help if a diagnosis is made with a child in the family, if they can reduce the family size. Promotion of neonatal screening and genetic counseling with comprehensive healthcare education is also of importance. Increasing community awareness on the burden and prevention of sickle cell disease, and integrating psychosocial educational interventions and psychosocial programs into comprehensive clinical management can provide vital support for sickle cell disease patients and their families. And then finally, promoting understanding among peers is crucial to improving the experiences of individuals with sickle cell disease. Next. Okay, so this is just a picture of Sickle Cell Foundation in Lagos. It's opposite the Lute Gate. That's Lagos University Teaching Hospital in Idiaraba there. They can actually offer so many services to individuals with sickle cell disease. One may want to link certain patients that may be able to afford certain interventions with them. But in summary, we have seen that sickle cell disease is the commonest genetic disorder among Blacks, and that Nigeria carries the highest burden of sickle cell disease in the world. Sickle cell disease causes also significant morbidity and mortality, leading to a range of psychosocial issues, depression and anxiety, leading to poor treatment adherence, increased pain, challenges with interpersonal relationship, a child being bullied, stigmatized, also opioid dependence, and financial strain among the psychosocial issues a child with sickle cell disease or their family may also suffer. Therefore, comprehensive care is crucial to address these psychosocial issues, which include, but not limited to, early identification and intervention, comprehensive support programs, patient, peer, and family education, enhanced pain management strategies, and integration of mental health into the clinical care is of importance. Next slide. So by conclusion, psychosocial maladjustment is known to aggravate such problems of sickle cell disease patients, their caregivers. The experiences of crisis, hospital admissions, and continuous transfusions result to stress, which poses a risk for the psychosocial dysfunction of caregivers and their family members. Clinicians and policymakers should provide the necessary psychological care and support to these individuals. Next. Next. All right, so thank you for your attention. If we have questions, this is the time to ask. Okay, so these are my references. Thank you for your attention. Over.
Thank you, Thank you, Dr. Hassan, for your presentation. We appreciate this topic, unlike the usual presentation of vaso-occlusive crisis, the issue of transfusion and what in the children. This angle has taken us on the broader issues affecting sickle cell patient. This is not only, I think, limited just to the children, because even some of our adults who are having sickle cell anemia are also passing through the same issues that he has raised in his presentation. And he has guided us through the necessary support we can give them to lessen the burden of the mental, social, and financial effects, not only on the individual that is suffering from the disease, but also the family and the health sector. Again, he has also talked about the issue of policy to make things easy for those that have, this disease condition. This afternoon, one of the patients on admission, who is a sickle cell patient, who was able to buy morphine for about 40,000, have to raise the same issue with me. Doctor, can government do something to make things easier for us parents with these children? Yeah, so it's the same issue that he has just raised in his presentation. And we hope that government and policymakers will be able to listen and be able to see how they can make life easier for, for these families. So thank you, Dr. Ishaku, for your presentation. Let me check if there are questions posted for you. Okay, yes, so there's a question here. Apart from the use of pentazocine and other opioids, what other effective multimodal analgesics are used to manage vaso-occlusive crisis in children with sickle cell anemia? Okay, so apart from the opioids, what other effective multimodal analgesics are used to manage VOC? Number two, is there any social and psychological support for children with sickle cell anemia in Taraba? Dr. Ishaku.
Okay, so thank you very much for those questions. Okay, so what are the other modalities of, aside from pentazocine and morphine? The truth is that the general teaching for any pain management is to use the WHO ladder of pain management scale. So one, you're able to establish the severity of the pain, for which in most cases, for the individual to present to the health facility with the complaint of pain, in most cases, they would have used the lower cadre of analgesics, such as paracetamol, the use of NSAIDs, be it ibuprofen, naproxen, diclofenac, and the rest. Those are things that commonly are being used at home. Now, yes, by the time we now talk of morphine or the opiates, usually is a severe pain that we are trying to now manage. So the thing is, even if one is using the opiates, it has to be used in combination with the other NSAIDs. For instance, we can't just climb the ladder up and stay up at the level of opiates without giving an NSAID. There must be an anti-inflammatory in addition to morphine or the opiates that we're giving. That is one. Then the other thing is there are actually things that generally one can also be able to use to reduce the pain. Use of fluids. We talk of use of fluid. We talk of use of, for somebody that is able to also accept it, you also encourage them to take hot feeds, such as tea, pap, when it is made hot. These are things that can also help. The other non-pharmacological method of pain, distraction, and the rest in some milder cases of pain, those also can be able to assist in the management of the individual. But caution also needs to be taken here with regards to use of fluid, because by the time we are using fluid, it's not just to make a prescription and walk away, because the teaching in those days used to be that, okay, you give 1.5% of what the individual is actually supposed to receive as a daily maintenance. But when you do that and you just walk away, in most cases, such individuals end up having complications. Complication is acute chest syndrome, which is more devastating than the bone pain crisis. So you see, in the attempt that we are trying to overhydrate, that can also result to another complication, because in most cases they are in painful crisis. Usually they will not come, they are rather bedridden because of the pain. And so you now give them fluid overload. Those are the things that precipitate or take them into acute chest syndrome. So even if your initial prescription is of that magnitude of fluid, they need to be reviewed, if not 30 minutes, an hourly review, such that you are able to see that the fluid prescription is not meant to be for 24 hours unattended. They need to be monitored so that you are able to stop the fluid or reduce the rate at which the fluid is being used. So those are the things. Now, the other question that has to do with what are the other or is there psychosocial modalities provided in Taraba State? Right?
Yes.
That's the question,
Yes.
right?
Yes.
Okay, so in Taraba State, if you know, the psychosocial support, they are actually diverse, but it can come from, we talked about the family, we talked about the health institution, that's the healthcare team, and then some other support groups that could be there. So for things like Sickle Cell Club, we actually do not have. We are working hard to see if we could be able to establish one. This year, June 19 actually is the Sickle Cell World Sickle Cell Day. We were opportune to have a group that supported that day for us, for children with sickle cell anemia. But we are hoping that we'll be able to get a club actually established for them, so that they can be able to get such support. When you have such a club, the issue of even this recurrent blood transfusion, you can be able to have an easy access to individuals that can be able to be potential donors and the rest. That can lessen the burden, and some other discussions that they can be able to also interact among themselves, that can also alleviate it. But at the moment, we do not have an established social support in Taraba State for sickle cell disease individuals. Thank you.
Okay, thank you. I think we have more questions, so maybe you just rush through to answer them.
Okay.
Yeah. Yeah, so there's another one. How do you manage enuresis associated with sickle cell disease?
Okay.
And number two.
Should I be taking them one by one? Okay. Enuresis.
Yeah, I mean,
continue.
If you know there are plenty, maybe you know how to manage
them.
Yes. So number two, how do you stem the issue of wrong genotype results as it relates to sickle cell in our environment?
Sorry?
How do we overcome the issue of wrong genotype results in couples?
Okay.
Yes. And then I think The third one is how can addiction to pentazocine be prevented in patients, especially in medics with sickle cell disease?
Okay.
Yeah, so I think this is the last question, if you can answer before we wrap up.
Okay, so let me start with the first. You said how can we manage enuresis in sickle cell disease? So
Yes.
it's actually it's the same approach with management of enuresis in general. But for an individual who you've already made a diagnosis of sickle cell disease, you can be able to say, okay, this is one known fact that can cause enuresis. But one will also have to look at the general patient or the individual and evaluate so that you don't just attribute to the enuresis as to being caused by sickle cell disease alone. So many other things could be responsible. You need to look at it, is it primary or secondary enuresis? If it is primary, it means this is something that the individual has never been able to achieve dry night. So you have to look at it. So if it is such, what is the cause of that? Is it other organic or non-organic issues? Likewise, if it is secondary, for those that usually they've been able to achieve dry nights and then it's now coming new, you have to look at some other things. In fact, sometimes it might just be that the psychosocial burden of the sickle cell disease has now made it in such a way that the child has noticed that there's a conflict in the home, and so that can actually result into secondary enuresis or parents being separated or divorced. So you see, the child is now taken to a new environment or being cared by an individual who new to that circle. So all those things, one will need to look at it. What are other causes? Is this child having diabetes? Whether it is diabetes mellitus or insipidus. So those are things that one will need to look at. Or is this individual having that infection? Is he having a congenital malformation of the spine? Those are things, spinal bifida, especially when it is occulta, it can also manifest with that. So it's actually a long process that one will need to have a proper evaluation of a child with enuresis. But the basic thing is you will not individual with sickle cell disease, we know that hydration is very important, it's a key in them. So you will want to also counsel this family that the fact that the child is having enuresis does not equate to the fact that the child should be deprived from water. Because once you do that, you are increasing the chances of this child having more and more frequent crisis. So the only thing we can be able to do at the initial stage is identify if there are other causes and then address it, set an alarm. Those are things that we can be able to assist the child with. There are more other things that can be assisted in the management of that. But in most cases, we try as much as possible not to go to pharmacological use of medications, except you have been able to see that it has to do with either neurogenic bladder or the rest that is resulting to that. Now, the management of wrong diagnosis of genotype, which is electrophoresis for a couple, how do we manage it locally? Well, it's a very challenging task, but you also have to look at it that in general, you have to see the family, and it's a long counseling session that one will have to seek. Now, the wrong diagnosis, at times, it's actually wrong. So, in the sense that the what do you call it now? The facility that gave that result might actually be genuinely wrong, or it might just be doctored result. So, but the question is looking for a wrong diagnosis. So you have to let them know that generally the diagnosis of uh, electrophoresis is what we do actually, is hemoglobin electrophoresis as against genotype that we refer to as. So we don't actually do genotype. What we do generally across Nigeria is hemoglobin electrophoresis. And generally, the hemoglobin electrophoresis has a lot of limitation. Uh, it, it can actually be altered by the voltage that is passing through the tank. It can also be altered with the medium that is within the tank, whether it is too alkaline or acidic for that medium. At the same time, the individual also interpreting the electrophoresis. It's not that it's something that is like a digital that is going to just show you this one is A, this is S, this is that. No. For instance, hemoglobin S, D, and G, they actually have the same band on the migration pattern in the hemoglobin electrophoresis. So an individual with that can just have, and then you now say, oh, this person is actually having AS. In the real sense, the person might actually be having SG, SD, and the rest. So you see that individual already has two abnormal hemoglobin genes. So those are things that can actually alter it. Now, the other thing again is, in general, the diagnosis of hemoglobin electrophoresis to say this is AA, AB, AS, and the rest is not ideally supposed to be the way that it should be. Rather, if it is electrophoresis that is being done, it has to come along with a full blood count with a film, minimum. In fact, for some, you will have to do sickling test, full blood count, film, and then the electrophoresis. You put all this together before you can be able to interpret and arrive at the diagnosis, since we are not doing a genotype. So those are things that you can be able to explain to parents. Now, the other thing again is an individual may actually be having thalassemia. So thalassemia may not necessarily, it's not a sickling hemoglobin. So because it's not a sickling hemoglobin, it will not show as an abnormal pattern on the electrophoresis. So if that individual, for instance, is having a thalassemia, then the wife is already known to be AS. Those are things that can usually have, by the time that the father now donates the gene with the thalassemia, and then the mother donates the gene with S, you see that child is already having sickle cell disease. So those are things that can actually also affect our interpretation and the reading. So those are things that we try to explain to the parents, because you try as much as possible as a physician to explain things scientifically, not trying, because in most cases, generally what this kind of scenario brings is the distrust. The one of the couple may start thinking of infidelity and the rest. You try as much as possible to disabuse their minds towards that aspect for the benefit of the child. And so you try, except if they now insist they want to go further and do, but in most cases, by the time we take care of it this way, generally they are able to either not, whether they are not convinced, but at least it's been helpful in such a way that you see that the family is able to carry along and take care of such, or accept the diagnosis. Those are the kind of challenges that one can actually encounter. Now, how do we manage addiction of pentazocine, especially among healthcare workers? It's very difficult. The truth about it is that the management of opiate dependence generally is it's a very difficult one. So generally, once you make it such a diagnosis, if it's a child, It's something that you have to start talking with the child. Let's also talk with the parents, because by the time we are able to talk with them, educate them with regards to the effect of this the implication of it and I think